also like to thank the Dr. Shulam in the urology department for allowing me to come do a summer internship here. I've really enjoyed my time working with all the faculty and the residents, and I look forward to the next 2 weeks as well. So my topic today is going to be comparing the surgical approaches for benign prostatic hyperplasia. The reason I kind of came across this topic was in my institution, we do a lot of GreenLight laser for BPH. And when I came here, we were doing some TURPs, and I just sort of asked the clinical question, is there an advantage to one procedure over the other? And I wanted to kind of look at the primary literature to see what the answer to that question was. That's sort of why I picked the topic. To start off, I have no financial disclosures or conflicts of interest with any of the manufacturers of any commercial products discussed in this presentation. So kind of an outline, I'm going to discuss the surgical interventions and how they work and what they are. Then I'm going to examine the GOLIATH trial, which is a study that evaluated the GreenLight laser versus TURP in a head-to-head fashion. And then after that, I'm going to address shortcomings of the study and also other questions generated by looking at other primary literature to answer that question. So obviously, BPH is a common problem facing older men. In 2010, the NIH estimated that 1.4 million men, or excuse me, 14 million men in the U.S. suffer from lower urinary tract symptoms suggestive of BPH. And obviously, BPH is something that dramatically increases with age. Being that the average age of our population is shifting right towards an older population, this is actually going to become even more of a common problem. So when considering treatment for BPH, obviously the first step should be lifestyle modifications and changes to medications. So things like not drinking water at night, changing diuretics through the morning as opposed to the evening, things like that. Then after that, medical management, which would be alpha-1 blockers, 5-alpha reductase inhibitors, things like that. From there, you could consider minimally invasive therapy. For example, like the new UroLift would be an example of a minimally invasive therapy that could be considered. But beyond that, from there, the next option would be surgical therapy. So obviously, transurethral resection of the prostate has been the mainstay of treatment for BPH for decades. It's an effective procedure. It's been around a long time. There's actually 150,000 TURPs performed in the U.S. each year alone. So it's a very common procedure that's been well characterized. Recently, however, the photoselective vaporization of the prostate with the GreenLight lasers came onto the scene. The first procedure was done in 1997, and since then, there's been over 500,000 worldwide performed. A key point to note for the entire talk, actually, with the GreenLight laser, since 1997, they've actually came out with several different products. Originally, there was one laser, then there was the 60 watt, then the 80 watt, the 120 watt, which is a lot of places use. I think we use the 120 watt here. And then the newest version is actually the 180 watt, which is what was studied in the study I'm going to talk about. So I wanted to kind of address some of the perceived pros and cons of the GreenLight laser before I looked at the literature. This was sort of thoughts that I had gathered from talking to different attendings and reading different articles and things like that. And one of them is that the GreenLight laser is supposed to be better, have decreased bleeding, shorter recovery times, and then also have the option of performing the procedure under anticoagulation. However, a lot of people complain that it's a longer procedure. There's a higher incidence of irritative symptoms, and then there's also no acquisition of tissue at the end that could be analyzed. So those are some of the just initial perceived pros and cons. So when I was, starting to look at the literature, some of the important considerations I mentioned was obviously that, because there's been so many different GreenLight lasers, a lot of the studies that have looked at this versus TURP have been using older lasers. So I tried to focus on the newer studies with the newest products because the older lasers have been shown to be inferior to the newer ones, and I wanted to look at the most current data. Additionally, I wanted to figure out what I thought was going to be meaningful outcomes in this study. There's both objective and subjective measures, things like the AUA score, max flow rate, post-void residual. Those are kind of some of the things I thought would be important, as well as adverse effects such as incontinence, irritative symptoms, bleeding, need for reintervention. And then lastly, I wanted to think about what was the durability of these results with respect to long-term treatment. I wanted to avoid, focusing only on that, there was success at 3 or 6 months. I wanted to try and look at longer-term outcomes, which obviously would mean less need for reintervention. So the GOLIATH study came out in 2014 by Alexander Bachman. It was a study in Europe. It consisted of hospitals from 9 different countries. And it was a prospective randomized control trial to evaluate the non-inferiority of the 180 watt GreenLight laser versus the TURP. The primary outcome they measured in this study was the International Prostate Symptom Score. And then the secondary outcomes they looked at were the max flow rate, among other things, and then also complications. One thing I wanted to point out, some of the key things that they ensured were, with randomization, were equal, was that the prostate volume, PSA, PVR, the number of people on 5-alpha reductase inhibitors, and the IPSS and Qmax were all non-significantly different in the study population, so I thought that was important to note. That's obviously there. So now taking a look at the primary and secondary outcomes. So this is looking at 6 months. We're looking at the GreenLight laser versus the TURP. And it's looking at the International Prostate Symptom Score, the Qmax, and then the complication-free period during 180 days. And I think for the numerous of these slides, I just want to explain what they mean by complication-free. They mean that a complication is designed as an adverse effect relating to treatment. So basically people that needed some kind of reintervention or additional or prolonged hospitalization. An adverse event, as far as complication-free, is not including short-term things like a catheter for 3 or 4 days. It's only for either intervention or longer-term things. So the key point with this slide is that of these 3 categories, all 3 were not significantly different at 6 months between the GreenLight laser and the TURP. So this is sort of showing at 6 months the efficacy outcome is not significantly different. So looking at the data a little more closely, the IPSS, we can see here that at 3 weeks, there was actually an improvement for TURP. TURP is the orange red line. But then at 3 and 6 months, it did actually wash out to the fact that there was no difference. And then same thing with quality of life score. There was a significant difference at 3 weeks, but then at 3 months and 6 months, there was no significant difference between the 2 treatment modalities. Additionally, looking at Qmax and PVR, there's the same trend. They both were successful without any significant difference in the data. Lastly, looking at the prostate volume and the PSA, both studies were able to show a decrease in both prostate volume and PSA. So they were significant compared to baseline for both treatments. However, compared to each other, there was no significant difference in the, at 6 months in prostate volume or PSA. So this was, I think, an important slide that this study really highlighted, looking at operative parameters and patterns of recovery. So the operative parameters here, what we can see is procedure time. The GreenLight laser, the average procedure time was 49 minutes, whereas the TURP was 39 minutes. Now, a lot of people I talked to, like this was a common thing that this procedure takes a lot longer. This study showed that it was only a 10-minute difference. However, the big thing to take away with this is that this is with the newest laser, the 180-watt laser. I'm actually going to show some data later in the presentation comparing the 120, which is currently used here, to the 180. But that's a big advantage of the 180, that it's much faster. So it was significantly different, but it was only 10 minutes difference. Now, looking at the recovery time, we can see they looked at some data. Length of catheterization was about 19 hours shorter with the GreenLight laser. Time to stable health status, which they defined as once you have a successful voiding trial or discharge, that was about 26 hours shorter. And then length of hospital stay was about 31 hours shorter. Now this data does seem higher, 65 hours for the GreenLight and 69 hours for the TURP. It's important to recognize, one, that that's including people that had to stay longer for complications. For example, the longest stay, for these are 524 hours and 357 hours, so that's the max. So that's one thing. And then the other thing is this is in European countries, so their standard of care might be a little different. But I do have another slide looking at another study showing the same time trend as well. The overall point with it is that the GreenLight laser is about a day shorter in the hospital. So complications, I know this is an important aspect. This is looking at people with complications at 6 months. And we're looking at several different things here: bleeding, urinary tract infections, irritative symptoms, and so forth. Some of the key things I wanted to point out is the majority of them were not significantly different in the p-values, including things like bleeding was not significantly different. But the one that did stick out was urinary incontinence. There is actually significantly more urinary incontinence in the GreenLight laser group as opposed to TURP. To kind of examine that a little further, we have a table here kind of talking about what the urinary incontinence was. For the majority of them, of the 16 patients, 12 of them were mild in the GreenLight laser, and then 9 of the 12 did fully recover by the 6 months. Only 4 were moderate urinary retention, and 3 of the 4 did recover. However, the TURP, you can see that very few people had urinary incontinence as opposed to the GreenLight laser group. Also looking at complications, the study looked at need for intervention, so adverse events requiring either invasive or surgical intervention. They broke it down into early and delayed. So in the first 30 days, the TURP group actually had significantly more need for reintervention. Most of that was either urinary retention or bleeding, but there was a significant difference there favoring the GreenLight laser. However, at 6 months, there was no difference in the need for reintervention between the two treatment modalities. So that was the first paper that came out with the 6-month data. Then after that, they came out with a 12-month update. Basically the same study, the same patients, and they just kind of updated the data for how people were doing at 12 months. Looking at the same values here, prostate score, the quality of life, Qmax, et cetera, without looking at every individual data point itself, the thing I wanted to highlight is that the p-value for all 6 of these categories between the 2 groups compared to each other at 12 months was not significantly different. So what this data sort of tells us is that at 12 months, the efficacy between the two treatments is similar. Additionally, they looked at other things in this 12-month update where they looked at functional and quality of life questionnaires. They used the standard form 36-question physical and mental health surveys, as well as the International Index of Erectile Function. And the key thing here is that, again, the p-values were not significantly different between the 2 groups, suggesting that overall people feel happy with the treatment and their erectile function is good. This is an important slide. This is looking more specifically at the irritative symptoms. Like I mentioned at the beginning, this is a perceived weakness of the GreenLight laser. And what this shows us is this is looking at the overactive bladder questionnaire and also an incontinence questionnaire. And what we can see here is for the 3, 6, and 12 month groups, the GreenLight laser is significantly higher scores, meaning more overactive symptoms compared to the TURP. So that sort of does explain the perception that there is more irritative symptoms with the GreenLight laser. That was also the same trend with the quality of life. And then also for incontinence, there was a significant difference with the GreenLight having higher scores, meaning more incontinence. Now, what the authors of the paper argue is that even though there is a significant difference in that the GreenLight laser is inferior to the TURP in this aspect, what they point out is that the baseline for these patients was around 44, a score of 44, and then by 12 months they had a score of 16.8. So they're still dramatically improved from the baseline. And what they also argue is that on a scale that's 78 questions, 78 points rather, going from 16 to 12 is only a 4-point difference. They argue that that degree of difference is not actually that significant, even though the numbers are significant. How clinically significant it is that they argue that it's not really that different. Additionally, they also asked patients at 6 and 12 months if they would do the therapy again and if they would recommend the therapy. And overwhelmingly, both groups recommended the therapy again at both time frames, and there was no significant difference between the 2 groups. So the last slide here for the GOLIATH study is kind of looking at complications, and they're using the Clavian-Dindo grading system. And again, without looking at every single point individually, the main things I want to highlight is that for grade 1, 2, 3A, and 3B, and then also overall, there's no significant difference in these adverse events requiring some type of medical or surgical intervention. So the conclusions from the GOLIATH study is that the efficacy and clinical outcomes are comparable at 6 and 12 months for the 180-watt GreenLight laser versus the TURP. Now, the efficacy is good, but the complication profile does vary. The GreenLight laser does have more irritative symptoms and also incontinence. However, the TURP does have more complications requiring intervention within 30 days. And like I said, the paper argues that the significance of the degree of variance of these symptoms is questionable. The other thing that the paper really pointed out was that postoperative recovery is superior with the GreenLight laser, with shorter catheterization times, decreased lengths of hospital stay, and decreased time to stable health status. So after going through the GOLIATH study, this brought up other questions that I wanted to kind of look at. One of them was, what is the longer term outcomes? I mean, yes, they came out with 6 months and then a 12-month update, but I was more interested in, is there any papers that go 2 years, 5 years, 10 years? The next thing I thought about is, I mentioned all these other different laser versions and the fact, there's the 120 and 180. I wanted to see if there was a study looking at the differences in outcomes and perioperative parameters. Additionally, I wanted to see how significant is it that the GreenLight laser doesn't provide any tissue that could be analyzed for diagnosis of prostate cancer. And lastly, what is the cost difference? Cost is obviously an important thing in healthcare, so I wanted to see if that's been looked at. So one study I found looked at using the GreenLight laser for BPH patients with and without urinary retention. The goal of this study was to see if the GreenLight laser is a viable option for people in urinary retention. I just sort of wanted to use this study because it did go a little further than the GOLIATH study. However, unfortunately, it did use the 80-watt laser. However, I do think that even though there is no study that with the 180-watt going longer than 1 year, I think we can sort of tell at least a trend from the data with this study. So what they basically show is the green is the blue is patients in non-urinary retention, and the red is people in urinary retention. And what I want to highlight is this point to this point, so 12 months and then 24 months, in all three groups, which is Qmax, residual volume, IPSS, quality of life, and IPSS, all three groups actually has a positive trend, meaning from 12 to 24 months, it shows that the efficacy is still positive. So again, it's not the same laser exactly, but it's, I was hoping to sort of just infer a point that there is some data showing that at least the 2 years, the outcomes are still good. However, with TURP, obviously TURP's been around a lot longer, so there's a lot more data, a lot more studies with it. This study looked at 10-year efficacy, and the study itself compared TURP to two other treatments, contact laser, prostatectomy, and electrovaporization of the prostate. The main things I just wanted to highlight was the TURP data, not so much the other two data, but they did look at up to 10 years, and they did get over half their patients to follow up at 10 years. And what they were able to show is that at 10 years, IPSS, quality of life, Qmax, and PSA were all significantly different from baseline. So that does show there is some durability of results with the TURP even at 10 years. However, you can sort of see a trend where the numbers are actually trending from like 2 to 6 here for IPSS, and Qmax is getting a little slower, and PSA begins to rise a little bit. So at 10 years, the parameters are increasing, getting clinically negative, but they're still significantly different from baseline. So the next question I had was about the different lasers. This study looked at 80 patients that underwent photovaporization with the 120-watt laser and 120 patients that had the 180-watt laser. And this study was performed by a single surgeon that had, prior to the study, over 500 cases with the GreenLight laser, so he was an experienced surgeon. And it's similar types of things they looked at: IPSS, quality of life, Qmax, PVR, and PSA. And they looked at patients at baseline 3 and 6 months. And then they also analyzed the operative parameters. So looking at the efficacy data, what we can see here is that we have the HPS is the 120 watt, the XPS is the 180 watt. And what we can see is that in IPSS, quality of life, and PVR and Qmax, there was no significant difference in the data. So what this is telling us is that the 180 watt compared to the 120 watt, as far as efficacy goes, is as good or better, because PSA was improved with the 180 watt, and then for most of these, the trend is actually in the direction that the GreenLight, the new 180 watt is better. But the key thing with this data that I wanted to point out is that the perioperative parameters and adverse effects are a little different. The mean operating room time for the 120 watt is 79 minutes, which I think is a lot of people in this room are probably more familiar with the GreenLight laser taking an hour and a half, hour 20 minutes, whereas the 180 watt laser was 43 minutes. So 36 minutes shorter for the procedure, which I think adds a huge advantage from the previous version, because that was one of the things that deterred a lot of people from using it. And then otherwise, the majority of the complications were actually not significantly different. However, there was less retention with the new laser. So what this sort of tells us between the efficacy data and the perioperative parameters is that the 180 watt laser is as good as far as efficacy and side effects, but it's better as far as speed compared to the 120 watt. So the next thing I wanted to look at was the incidental diagnosis of prostate cancer with TURP. This was just sort of a question I had because I know that obviously with the TURP you get tissue for analysis. Now, prior to the PSA era, 27% of prostate cancers were detected at the time of TURP, and the ODO group hypothesized that incidental diagnosis of clinically significant prostate cancer was no longer of significance with the modern PSA era. So what they did is they did a retrospective review and looked at 793 patients that had a TURP over a 5-year period, and they excluded anybody that had a preoperative diagnosis of prostate cancer. And what they found is that of the 771 patients included, only 11 were diagnosed with prostate cancer, so only 1.4%. 10 of those were clinically insignificant Gleason 6s that they ended up just doing active surveillance as opposed to operative. And only one person had a clinically significant Gleason 7 that they did an operation on. So what this data sort of tells us is that it's not getting tissue, at the time of a TURP is not important. One, we're finding a very few amount of prostate cancers this way, and two, we don't want to find, clinically insignificant cancers. So what this is telling us is that if somebody has, elevated PSA, clinical symptoms, physical exam, we'll find prostate cancer with a biopsy. The TURP isn't giving us anything that we can't get outside of that. And then the last point I wanted to kind of talk about was the cost. So this group sort of compared, this is a Baylor, did a retrospective perioperative cost analysis for all patients that underwent TURP TURP or the GreenLight laser during a 12-month period. They included both direct and indirect costs, and they analyzed 250 TURP patients with 220 photovaporization patients. And what they showed is that the first thing I want to point out is that the payer profile was not significantly different. So, Medicare versus private insurance, that would have influenced the study, not significantly different. This data here is showing the mean days of hospital stay. So this sort of reflects the other data I showed you from the GOLIATH study a little bit. The numbers are a little different, but the trend is the same. For them, the GreenLight laser was 1.73 days. And again, this is adjusted for people that stay longer for complications. And then the TURP was 2.59 days. Again, same adjustment. But the key point is, again, it's about a day difference. So that influences cost. Looking at the costs themselves, overall cost, the difference was about $800 from $42.66 to $50.97. And that was significantly different. So what's that showing us is because of the shorter recovery times, the GreenLight laser is having a reduced cost compared to TURP. So final conclusions, the GOLIATH study did successfully demonstrate the non-inferiority of the photovaporization of the prostate with respect to efficacy compared to TURP at both 6 and 12 months. Irritative symptoms and incontinence continue to be the biggest drawback for the GreenLight laser from both the patient's perspective and the physician perspective. However, the technology is continuing to improve. They're constantly coming out with new lasers. The newest one did 180 watt. And these new lasers are still demonstrating good outcomes with faster recovery times and less costs. This is probably the biggest barrier to studying the GreenLight laser versus TURP because they keep coming out with new lasers. And so it prevents having longer-term studies with the GreenLight laser because for example, this GOLIATH study, they continue to the 5-year point. They'll probably come out with a new laser soon that'll sort of make it 180 watt less important to know the watt data on it. On study, there's a big barrier because of this technology, but also it is showing improvement in parameters. So what's next? We'll have some studies like I mentioned. The technology is improving. The last thing is we have larger studies, patients, thousands, hundreds. That'll give more data. That we can answer the question how they compare. So with that, are there any questions?
I was wondering when you offered the GOLIATH study and the other video, during hyperplasia, this is why you're a higher rate of incontinence after laser prostate stress is caused. There's this inadvertent straight therapy.
Yes. So that is what goes in the paper. Most of the time they talk a lot more about the irritative symptoms, why they thought with the sloughing of cells and things like that. But yeah, exactly. They thought just messing with disrupting the sphincter is the most likely culprit in that case. Question.
Are you aware the authors had any involvement?
So in the GOLIATH study, the trial was funded by AMS, but the authors had no affiliation with it. Yeah, I wrote it.
I have a question and a comment. So when you present patients, you talk about the GOLIATH and say there's a higher risk of irritative incontinence because I've been involved in several litigation issues just as an observer, and when men's interpretation of incontinence is very different than women, they don't understand what incontinence is. As soon as they get one drop, their life is brutal. Whereas women, you know, they actually tolerate a lot more. See, that's why my wife calls them all the time. Women are a lot more patient. But this is a significant issue in my mind of how do you counsel the patient when you're sitting there and, you know, you say, okay, let's just do a procedure on you. You're going to say, there's a data out there that shows, you know, even at 12 months, there might be some. What would you say? So then the second, I'm just going to make a quick comment, which, you know, this is a great talk. I just want to give you sort of history. I thought Dr. Foster was going to mention the study, research study of BPH by the NIH has followed an interesting path. They all have different letter acronyms because the first big study was an MTOP study, medical treatment of prostatic symptoms, with a forearm study, followed by, they wanted to look at MIST. They never went, MIST stands for minimally invasive surgical trials. They wanted to do randomized comparison. GOLIATH beat, you know, and they dropped that sort of idea, and then they went into alternative and complementary medicine with BPH for the Saul Palmetto trial that was published in JAMA. So I find that the NIH's interest in this area was there, and Harris was a PI on the MTOP study. NCAM, which is the alternative and complementary medicine. But anyway, so what do you think about consent?
Well, I think consenting, obviously, it's important to mention, but you know, one of the things in the data I pointed out was that looking at both the irritative symptoms and overactive bladder incontinence, the study still showed at 12 months they're still much better than baseline. So it's not like it got worse, you know, or you know, significantly different as far as a negative standpoint. It still got much better, just not as good as the TURP. But I definitely still think it's, you know, clinical responsibility to, you know, to mention that when consenting and discussing surgical options.
So first, I thought that was a really nice presentation. I thought
Thank
it was
you.
very, like, better than just a superficial reporting of the literature. I like the way you sort of thought about the clinically relevant questions and really tried to analyze that. So I appreciate that. I thought you did a great job. A couple things just in terms of when you're looking at the literature. One of the things when you mentioned that there was a difference, it might be statistically significant but not clinically significant. I think that that's important. A lot of the patient-reported outcomes or subjective outcomes, there's more and more focus on what's called a minimally important difference. My guess is that that exists for the IPSS. So that's something just when you're presenting to mention that, especially if you know the difference has to be a 10-point difference and there's only a 3-point difference. So that can be important. Another thing is when you're looking at long-term data, there are changes that occur, and I totally agree. Like 12 months is okay, 2 years is better, and we have the same sort of perception in the female literature. One thing to remember with the lower urinary tract, there are changes that occur with aging. It can also affect, you know, like detrusor underactivity or increasing. So again, just something to include when you're presenting or thinking about it. And I totally agree with Dr. Singh's comment about you do need to see who's sponsoring these. And even though it would be hard to poke holes, you know, you look at their primary outcomes, everything was carefully done, rigorously done. It's still, people tend to, there's always some inherent bias. It's always nicer to have a non-industry supported study. Those are hard to do these days, so sometimes industry, you can still glean important information from that. So I agree with that statement, and also with moving forward with non-industry supported studies, the best you can do. And there was the one thing I thought was missing from that study, they did have a patient satisfaction, because in the female literature, new onset irritative symptoms or persistent is a major driver of dissatisfaction. So I thought it was curious there wasn't more of a satisfaction difference, especially because what Toby said, the incontinence thing plus the irritative thing would make me concerned if I was counseling like a family member about which one to get. So the satisfaction literature can sometimes capture all of that, right? Like improvement plus de novo symptoms. So there are some other measures that are global impression, like patient global impression of improvement or satisfaction. And something like that overall, how is your bladder condition compared? So that would have been a nice addition to that study. And my bet is that moving forward, more studies will include that. But overall, I thought it was really nice. I was going to ask about the mechanism for the irritative and incontinence. That's already been answered. Thank you.
Thank you. Thanks so much.
All right. Next, we have Shinan Chen who was born in China before immigrating to the UK and finally settling in Canada. He obtained his bachelor's degree in immunology from the University of British Columbia and is currently studying medicine at Brown in addition to obtaining his MPH at Harvard. Some of his extracurricular activities include a sub-internship with the Director General at the WHO, Dr. Margaret Chan, and serving as a medic in a UN refugee camp in the West Bank. Some of his research interests have included prostatic artery embolization for the treatment of BPH, and he's currently working with Dr. Joseph Renzulli on building the MRI fusion biopsy program at Brown. Shinan's other interests include playing the alto and soprano saxophone, traveling, golf, and is a self-described foodie. Shinan was initially set up for a formal sub-I with us for an entire month. However, due to an upcoming planned surgical procedure, he was unfortunately only able to do a one-week observership. Nonetheless, he has volunteered to give us a quick talk that he had prepared for another sub-I, and we're very grateful for
him. Thank you very much for the introduction. Dr. Shulam, Dr. Foster, faculty and residents, good morning. Today, I would like to talk about a very interesting idea I learned a few years ago at a national meeting, RSNA in Chicago. And I've been following Dr. Stoller's from UCS SF publications. Recently in 2015, he published this paper describing this idea. So first of all, I just want to make sure that I have no financial conflict. Let's start with the case. So Ms. MR is 46-year-old female presenting with one-day history of flank pain, nausea, and gross hematuria. Her past medical history include hypertension and kidney stone. She's currently taking 25 milligrams of hydrochlorothiazide and has no drug allergy. In the ED, her vital signs are stable. She appeared to be in distress and in pain. Pertinent positive labs include elevated creatinine of 2.1 and urine analysis showed 3+ blood. Then contrast CT showed 11 millimeter proximal right ureteral stone, and ultrasound showed grade 2 hydronephrosis of the right kidney. So what are the treatment options for Ms. MR? Prior to 1980, treatment for stone was major intra-abdominal surgery, and is really hardly used nowadays with a few exceptions. Since 1980, many minimal invasive treatments have become available, including SWOL, PCNL, and ureteroscopy. In order to understand how microbubble works, we need to understand the physics behind SWOL. So here's a demonstration of how SWOL works. With this very big bulky machine, it generates a shock wave and in turns to fragment the stone. This was first developed in the 1980s in Germany, and it used focused electrohydraulic or electromagnetic energy from outside the body to generate focused shock wave, and the shock wave in turns induce formation of cavitation bubbles in vivo. So what those bubbles do is when they collapse, they release a tremendous amount of energy to fragment stone, and in turns allow passage of a small fragment. However, there are limitations of this idea, including anatomy of the patient, location of the stone, and the distance. Complications from shockwave include gross hematuria, hematoma, AKI, and damage to surrounding tissue. So in recent years, shockwaves have become less frequently used in treating kidney stones. One reason is that newer generation machine has smaller focal zone and has become less effective. And another reason is the availability of the minimal invasive procedures. Here's a very important question. Could we actually apply the principles of microbubble cavitation using endoscopic approach without this really big bulky machine? If it is possible, it will further make stone treatment more minimal invasive. So what are microbubbles? They are made of inert gas core stabilized in the shell, and they're designed to be 0.1 to 10 micrometers in diameter. And they're also engineered to target very specific target, and they're usually short-lived, about 15 to 20 minutes. Here's a picture of a microbubble. As you can see, there's a core surrounded by a shell, and you can engineer anything like with antibody and to target anything in the body. There are two major FDA-approved brands in the United States. One is called Definity, one's called Opticent. In recent years, microbubble has become a very, very hot research topic in the world of biomedical engineering. It has growing and significant role in medical therapeutics and diagnostics. In the United States, it's only FDA approved as a contrast agent to identify cardiac structure anomaly during echocardiogram. However, outside the United States, has been widely used in other fields, including cancer treatment, coagulation, thrombolysis, and most recently I read a paper about regulating kidney, rejection after kidney transplant. So the next question is, does it work and is it safe? Dr. App's team from Rush University in Chicago demonstrated that using microbubbles as a contrast agent reduces observer variability in echocardiogram. It also showed it has great potential in decreasing imaging costs, mortality, and radiation exposure. Another team of scientists from Minnesota investigated the safety of microbubbles used as ultrasound contrast. So in 418 consecutive patients with known right to left shunts, no neurologic or embolic adverse events were found. Only one patient reported transient back pain as a secondary complication. So by conjugating antibodies to microbubbles, it allows its accumulation in renal vasculature. Dr. Dillman's team took interest in finding out the effect of microbubbles on renal physiology. In their study, they found that capillary rupture occurred in rats when ultrasound energy is set as highest index. However, such things were not observed in larger animals such as pigs or rabbits. So what about kidney stone? Here's a proposed approach of how it works. After preparation of microbubbles, we can inject it into the kidney and then use ultrasound energy to activate the microbubbles in turn and then to fragment stone. So how do we target kidney stone? And microbubble can be engineered ex vivo with bisphosphonate group specifically targeting hydroxyapatite. And as we know that most kidney stone are composed of, have a significant portion of hydroxyapatite. And also we learned from treating osteoporosis, bisphosphonate has high affinity to hydroxyapatite. So how can we deliver the kidney stone, the microbubbles? So this microbubbles can be delivered via ureteroscope or also that can be delivered percutaneously. And excess bubble can be washed away. Energy source-wise, we can use low-frequency electromagnetic radiation or a standard ultrasound unit to activate the microbubble. And this forms energy propagate very well through tissue without strong interaction. Other than using standard ultrasound machine, energy can be delivered endoscopically under fluoroscopy, which allows real-time visualization. So in this way, we're able to replicate the mechanism of microbubble cavitation generated in vivo by shockwave. Here's a picture from Dr. Stoller's recent publication. It shows ex vivo cavitation by microbubbles. And below are the images of stone fragmentation captured by high-speed camera. So let's come back to the case. So how we treated Miss MR. We treated her with ureteroscopy with laser, and then afterwards with stent placement. So hypothetically, if we treated her with microbubble, it's possible it is a less invasive procedure and has less radiation exposure. And when it compares to shockwave as well, it may have less adverse effect due to significantly less energy delivery. So Dr. Stoller's team believed that microbubbles have great potential to be the next frontier in kidney stone treatment and could further contribute to stone fragmentation and diagnosis. And their team also made a very, very good YouTube video, which is available online. Last but not least, I want to thank you for having me here. I've enjoyed my rotation. No questions?
One of the things I was thinking about, looking at that last picture, could there be a role for this perhaps not as during the primary initiation of shockwave, but you have one stone with a lot of volume relative to very little surface area,
yeah.
Compared to a stone that's undergone some shockwave, broken up into several, but still persistent pieces, with a significant increase in surface area relative to the same amount of volume. Could be applied as a salvage approach to failed physical vessel.
Well, I think the entire idea behind this is that they're trying to think of ways to first to reduce complication and also to make it more minimal invasive. It's really just it's kind of like they're proposing an alternative treatment plan. I don't think this actually intentionally used as like a supplement one to use after failed as well. And also another important thing is just it really does allow real-time visualization to see stone fragmentation. I mean, all this information is all in preclinical stage, so there's no real clinical data comparing to other methods. This is all hypothetical right now.
Did they talk about the affinity of the microbubbles to the stone?
The affinity?
How strong is the bond?
I don't know if there's any measurement, but the bond is very strong. It's like basically they follow the idea of treating osteoporosis, which is like really, really strong affinity.
You and I talked about this in the OR yesterday.
Yes.
For the group, I think for this to have any traction, it would have to make a major difference in the efficacy of stone breaking,
sure.
Right? Because what you've done is with this changed a non-invasive procedure into an invasive procedure. You've changed a procedure that 90% of the time does not need to be done with general anesthesia to a procedure that probably is going to be done with general anesthesia. So
that's true.
That trade-off is going to be a pretty big difference.
Yeah.
I just want to make a comment about actually the two talks that are very interesting because I'd like to hear someone actually give a talk here about application of technology in urology. You know, I've seen talks about early adopters versus late adopters. I know this isn't available. Previous talk was about using lasers, which is available for urology. The whole question is, what is the balance when you apply new technology to something we do every day in clinical medicine? Because the purported it's always better to use new technology, but is it really better? And it's a difficult question. I'm bringing this sort of a generic, trying to find the common link between the two, because eventually this new technology wants to look for a place in clinical medicine. I'm sort of following up on Dr. Singh's message, but sometimes I think technology, it's a trade-off. It's technology goes faster than we know how to apply it, basically. And some people miss a boat because if something really does work, and the late adopters completely miss a boat because the people who adopt everything will obviously try a lot of things that don't work. So it would be interesting to know all the different ways of thinking of how to adopt new technology within clinical medicine. And maybe Dr. Shulin has comments because they probably talk about these kind of things all the time. What's the best way? Is there a best way?
There's some ethical considerations too, right?
Sure. But I'm always challenged because okay, I got this great new device, but go ahead and try it because it works great. Does it really? And how long do you wait? What kind of data do you need? And what's the incremental? There are a lot of questions I think that are sort of by the time you figure out how to answer all this, miss the whole boat.
This should be very critical in these non-inferiority studies. That the next obvious step, even if it's superior is the cost analysis, a value-based assessment. Is this new technology really worth the application? If it's not making a difference, it's worth it for the healthcare industry.
So cost, of course I didn't mention. It sounds like money is a big deal, right?
Not cost, but value.
Value.
Okay. If you have
just even if it's not a serious one, again, should we comply?
I mean, I think with respect to the GreenLight, I think the other issue is the patient comes in the door asking about it. Some of these things get advertised to patients, so they hear it from their friend or this or that. And doing a fair amount of BPH. I mean, there's not an insignificant number of guys who come in basically saying, "I want the laser," notwithstanding, the paucity of long-term data. And you have to, I mean, that's a real-time issue that you have to deal with face-to-face. There are some ethical issues. And then it's, the same thing happened with all these iterations of slings that we've done over the years, many of which have fallen overboard. So.
Thank you very much.
Thank you.